So good evening. This is Dr. Famuyiwa. I'm excited to be here. We have a special guest, Dr. Mansouri-Attia.
You
All
got
right.
it.
Right. So forgive me if I butcher your name. I'm going to let you pronounce it in a second. But tonight we're going to be talking about understanding the immune factors that are affecting repeated implantation failure. And also some of these same factors can affect recurrent pregnancy loss. But in the context of today's talk, we're going to focus on repeated implantation failure. That's when you put in normal embryos and you can't explain why they're not taking. Now, tonight with me, Dr. Mansouri-Attia works with a cutting-edge scientific company called Pregmune that has been at the forefront of helping us understand these factors better and come up with ways to treat it. So, Dr. Mansouri-Attia, right? I'm going to let you introduce yourself and talk a little bit about your background. Your background is so exciting.
Hi, everyone. Very pleased to be here tonight with you. So as you say, you didn't butcher my name. It's Dr. Mansouri-Attia. I'm coming from France. I'm a scientist. I've been working in the reproduction field for the past 15 years. I did a PhD in France using biotechnology of reproduction and looking at their effect on the endometrium, on the uterus. So I came in the US a little over 10 years ago now to try to look for marker of ovarian cancer. I did a postdoc in Houston, and that's what brought me in the US, working at Baylor College of Medicine. So for the past 10 years, I've been working in clinics, first as a scientist for Braverman Reproductive Immunology, an IVF practice based in New York. And since 2020, I've been the CSO for Pregmune. So as you described, Pregmune
Chief
is
Scientific Officer. Chief Scientific.
Exactly, yeah.
Yes.
Pregmune is a biotech company trying to find answers to issues you may have in regards to your fertility, recurrent pregnancy loss, recurrent implantation failure. We are using immune tests in addition to AI to try to predict chance for success based on those results.
Excellent.
So I'm a scientist first. I'm a wife. I'm a mother of 3, so I'm quite busy.
Amazing. Yay. I don't know how you do it, but I'm so fascinated. And I'm just so happy to know that there's a company like Pregmune, because this is complicated. This is complicated information. Patients are confused. The physicians are confused. It's really complicated. So tonight, what I'd like us to do is try to demystify some of these problems a little bit. And I'll warn everybody, there's a lot of topic to cover. So we may not cover everything. We may split this talk in two. So Dr. Mansouri-Attia, could you just briefly tell us what is reproductive immunology? What do we know that to be?
Yeah, so reproductive immunology is the science that studies the interaction between the immune system and the reproductive system. So most of the time, pregnancy is described as interaction between the endometrium and the embryo, and you may have heard the analogy with the seed and the soil. Where is the sun? Where is the sun? Where is that light that will promote the pregnancy, facilitate the implantation of the embryo? Very often, immune system is totally disregarded. It's really the last step taken to try to explain infertility, and that's really a shame.
Excellent. So let me just quickly say, I know you said it so fast, people may not get it.
Sorry.
The seed and the soil.
Yeah.
What that means, we talk about the seed, the baby, the soil, where it's going to implant. And really it is like a little tango. It's a very complex dance. If you put the seed in, is the soil defective or is it a bad seed? And you could put a good soil. Well, their interaction, kind of like the lock and key mechanism, right?
Exactly.
That it has to. So let me with that open into some of the things that your company tests for, right? So I want to ask you, explain how when we say parental histocompatibility, what is that lock, right? The lock on the uterus, and what is the key that has to fit into the lock in simple terms?
In simple terms, yeah. So that's quite novel, and we are one of the few testing for parental histocompatibility. So what that means is that we are going to look at both yourself and your male partner, and we are going to screen for a full HLA typing. We are going to look at HLA. HLA stands for human leukocyte antigens, and those are proteins present on the surface of all your cells. They are playing a little the role of a barcode specific to you. And there will be sensor of self versus non-self. So anything that will be foreign to your body will be recognized as non-self, and HLA antigen will play that role of sensor. So we are looking, we are looking at both partner HLA typing. We are looking at ABC, HLA, DRB1, DRB345, DQ alpha, and DQ beta. And we are going to compare those two HLA profiles to try to determine if there is any similarities, which is bad for the pregnancy. The pregnancy and the maternal immune system want to have a very different HLA from the fetus. Again, a reminder, the fetus is 50% your partner genetic. So it has to be recognized as foreign to be able to promote that answer and that response of immune tolerance.
So Dr. Mansouri, so let me just, again, try to bring the language down a little bit for people. The HLA is, would you say that would be the key that's on the surface of the embryo, correct?
You are, it's on the surface of the embryo.
If we look at our analogy of key and lock, the HLA is the key, there must be a lock on the uterus. Correct?
The lock will be looked at when we are testing for the KIR. So the KIR are receptors, this time that are not coming from your partner. It's on the surface of your natural killer cells. So it will be in the uterus. And those receptors are present on those uterine NK cells, and they will recognize the HLA-C present on the fetus.
Excellent.
And again, the HLA-C present on the fetus will be part yours and part your partner. That's why we are screening for both.
Excellent. So now let's explain. The natural killer cell in the uterus is not necessarily a bad thing, correct? Because so they're just immune cells that are responsible for protecting, correct?
Correct.
So, yeah. Okay.
We are going to initiate an immune response that will promote immune tolerance.
Exactly.
And so we have, you mentioned the key lock system. It's totally a very good explanation.
Yes.
Having a specific key type doesn't mean that it's a bad thing. It's just that we have to find the right key. And
exactly.
You cannot modify your genetic. You cannot modify your partner genetic. Right. Sometimes the key lock system is not the right one, is not optimal.
Exactly.
And we can detect that and we can treat for that to try to boost the immune tolerance.
So if I were to explain it in lay terms, the lock, the KIR, killer immunoglobulin-like receptor that's on the natural killer cell, well, the natural killer cell in the uterus at its normal level is supposed to tone down the cytotoxicity. It's supposed to tone things down so that you don't attack the baby. So there may be a problem when that toning down is not happening, when the lock is hyperactive, correct?
That's totally correct, yeah. So it tones down the immune system, but it also do a lot of things. It will help in secreting some factors that will help the embryo to implant. So that will be chemokines and cytokines being secreted and trying to help the invasion of the embryo to allow a successful pregnancy.
Sorry. Now that we break it down into key lock system, just to make it easier on people, HLA is the key on the baby, and that key is half mom, half dad.
Correct.
The lock is the KIR receptor on the uterus.
Correct.
Now, we could have problems there, right? The key's not fitting. You could have a square key to a round hole, and you test for that. And we see that in some patients, right? So what would that testing look like for that abnormal key lock interaction?
So again, in itself, having a specific key is not an issue. It will all depend on what you have in front. What is the key? So for some people that will have a key AA haplotype, which is a bad prognosis usually, if they have the right embryo with the right HLA-C content, that won't be an issue. So it's a little complex. There is the key, there is the lock, but there is also
combination.
A combination, yeah.
Yes. So you have to have the right combination.
Correct.
Now, it could be that someone has the wrong combination, right? And like, you know, a patient could have a wrong interaction, like they have you were telling me the HLA-C, right? And if it combines with the KIRA, may be a bad combo, correct?
Yeah.
And if that happens, what can we do about it?
So there are drugs that help boost and promote immune tolerance. There are drugs that will prime your uterus by promoting the recruitment and the secretion of something called regulatory T cells, very important cell. It's an immune cell that will prime your uterus ahead of time, ahead of the pregnancy. You can see increase of those cells in the second half of a menstrual cycle. And when the embryo comes into the uterine cavity, we see more and more of those cells being recruited from the blood to the uterus, and they will be sequestrated. They will stay in the uterus and will promote Th2 response. So that will be an anti-inflammatory type of response.
Okay, great. So again, I invite anyone to please turn in your questions. I don't want this to fly over your head, but I'll try to break it down, as simply as I can. So we want to give medication that will tone down the, I guess one of the ways to look at an immune response is when the body is seeing the fetus as foreign tissue and it gears up to do battle. So you give drugs that will suppress that immune attack on the baby, correct?
That's correct, yeah.
Excellent. So we know that it's not just the key lock mechanism that can be wrong. One of the things that could be wrong would be an autoimmune system, right? So this is separate from the key lock. This is when the body itself is actively producing substances that can attack the baby, correct?
That's correct, yeah.
Can you mention a few autoimmune things that maybe we didn't even know about until we did this testing?
So we are looking for anti-phospholipid antibody. Those are antibody that will target any cell. Any cells in your body have on the membrane phospholipids. So those antibody will fix on those cells, any cells, including blood cells, and that will make your blood thicker and will increase your risk for blood clots. So if there is a vascular impairment at the maternal fetal interface, that may cause also a loss. So we are screening for different anti-phospholipid antibody, beta-2 glycoprotein, anti-cardiolipin, anti-phosphatidylserine, and we are looking at those antibody, try to determine if you are positive, and if you are, we can also determine the concentration of those antibody. If it's high, we can recommend some therapy So the most simple is the use of low-dose aspirin, baby
Correct.
aspirin, very easy. We can also recommend the use of blood thinner that you will have to start prior to conception and stay on it through the pregnancy to try to minimize the risk of those little blood clots.
Exactly. So the antiphospholipid antibody syndrome, it's not very common, but we do see it sometimes. The mechanism, that we think that they cause either miscarriage or prevent implantation is at the level of the embryo uterus. They can cause microclots, correct? That act as barriers preventing the placenta from properly growing and implanting. And that's the reason why you would give a blood thinner to prevent that. Yeah. But also talk a little bit about what about people that develop antibodies against their own thyroid gland, or they develop against their own adrenal glands? Can that be an impact in at the level of the uterus too? I mean, the thyroid is all the way up here, right? What's that doing down there in the uterus?
So we are screening as well for a full thyroid panel, and most of the time the physician will look at your TSH, and they are running a reflex testing, which means if the TSH is out of the normal range, then they will look at your T3, T4 level, which are the two thyroid hormones. Very, very rarely they will look at anti-thyroid antibody, which we do. We are looking at the thyroid peroxidase antibody, thyroglobulin antibody, THR receptor antibody. Yes. And we have seen in the bibliography few studies showing that TPO antibody can directly bind to the trophoblast and degrade it. So
isn't that crazy?
Yeah.
All right. Let me say that again.
Yeah.
Your body wakes up one day, produces antibodies that attacks your thyroid. And initially, some of these antibodies, before they suppress the thyroid, they may actually flare it up, and then they burn it out or they shut it down. These same antibodies, what Dr. Mansouri-Attia is saying, these same antibodies produced by your body that attack the thyroid can attack the embryo. Wow.
Yeah.
And one thing that's really fascinating with the thyroid is a lot of times there may be no symptoms, right, until it gets worse. And a lot of times we discover these patients because we discover their thyroid abnormality because we're busy trying to figure out why they can't get pregnant. And we find that out. But more importantly is, can you talk about, there's another immune problem we haven't even mentioned yet, and that's lupus. That's the great mimicker of every disease known to mankind. It's very difficult to diagnose when it's starting to present and may present as repeated implantation failure. How does your testing detect this?
So we are looking as well for a full ANA panel, which is anti-nuclear antibody, and lupus, SSA, SSV antibody are part of the panel. So most of the time, the patient can have some clinical symptoms, but really not much. And in their medical history, they have to fill systematically a questionnaire. And we see that there is some red flag that are confirmed then by that testing, and we can see some positivity for those ANA antibody. And we suggest the patient to consult with a rheumatologist to go a little deeper and have the proper diagnosis.
Yeah, that's fascinating. I think one of the things that blew my mind was, one of the recent testing that we did where the patient had such high inflammatory markers that we couldn't even pinpoint, is she starting to get lupus? Is she getting rheumatoid disease? Same factors, but all her inflammatory markers were elevated. And could you comment about that, and what kind of treatment would you recommend for a patient like that, who has no symptoms, by the way?
Yeah. So besides the APA and antibody, we are looking at inflammatory marker. We are looking at what we call Th1 on Th2 ratio. So that will be a ratio on helper T cells, a specific immune cell type, and we are looking at interferon gamma on IL-4, it's basically a marker of your inflammation. And we see sometimes patients with huge level. So of course, if you have too much inflammation, that will completely impair the implantation process, and you may fail your transfer.
Wow, amazing. So what kind of treatment would you give such a patient?
Prednisone, corticosteroid.
From when to when?
So prednisone is usually starting on first day of a stress, and it's continue up to 12 weeks. So we are starting with lower dose, and of course, if the patient gets pregnant, we can monitor the pregnancy for a panel of different factors, and we can adjust the dose depending on the stage of the pregnancy, and if we see a spike of XYZ cytokine that are shown to be detrimental to the pregnancy maintenance. So we can monitor the pregnancy and adjust the dosage as we go, as the pregnancy progresses.
Yeah, we do know also that steroids by themselves are what is called immunomodulators, right? So they help to suppress also the attacking antibodies or whatever. So, but in addition, it will lower inflammation.
Correct.
So it looks like inflammation is one of the bad things that could happen, and completely asymptomatic.
Yep.
So that's one of the testing you look at. Let me segue a little bit into inflammation. We talked about the inflammatory markers that people may not know. One of the things that we now know, most Americans are metabolically unhealthy, right?
Yeah.
And by their lifestyle, they increase, or even it could be genetic or environmental, increases the inflammatory condition in which their body is in. How can you detect that? What kind of markers can you look for? Is it their food? Is it their, what other inflammatory markers can we look at?
So we are looking, we are running a full metabolic panel that will let us know if you may have PCOS. We are obviously looking at your AMH level, your progesterone level. We are looking at your glucose level, insulin level, testosterone level, what else? SHBG level. And we are looking at all those, and we are able to tell you if you meet, two or more criteria based on the Rotterdam criteria to tell you if you have PCOS or not. If your A1C are borderline elevated, we can tell you, of course, if you have pre-diabetes. If it's very high, we can clearly tell you that you have diabetes. So if the results are elevated or abnormal, we can also recommend a few drugs such as metformin to try to restore a more balanced metabolism. Metformin will help to reduce, of course, your glycemia, but it will help also to improve your oocyte quality, down the line, embryo quality. It also promotes implantation. So it's really a very good drug to try to help.
Excellent. Can you mention a little bit about the omega-3 evaluation and omega-6 evaluation you do, and what is that, if patients ask?
So we have a full section called nutrition, and we are screening for a full fatty acid profile. So we are going to look at your omega-3 fatty acid. So those are the fatty acid that will promote anti-inflammation, that will help temper down the inflammation. In opposition, we have the omega-6 fatty acid that will promote inflammation. And we are screening for a lot of those, and we are establishing ratio, and we are able to tell you your omega-6 on omega-3 ratio is above 10. We need to bring it down significantly prior to conception. And for that, we are using fish oil. We are using fish oil that are very highly concentrated in two omega-3 fatty acids, which are EPA and DHA. So usually we can restore optimal level within 4 weeks with the right dose.
Excellent. And then do you monitor that?
So we used to monitor it every 2 weeks, but with the number of patients that we tested, we do see that let's say you have an omega-6 on omega-3 ratio above 10, 2 weeks at 6 gram EPA DHA will be sufficient. You then decrease that dosage, to 4 grams for another 2 weeks, and you use a maintenance dose of 3 grams for the rest of the pregnancy, and you will be within those optimal range.
Excellent.
So no need to monitor.
So when I look at the tests that you guys do, it's really incredible. It's a very, very comprehensive and extensive array of tests. But it's not just doing tests, right? You're just not, anyone can order all those tests, right?
Yeah.
But the question is, how do you make it make sense? You're looking at so many things. How do all these tests make sense? And how does it help you come up with a unique assessment for each patient and thereby be able to make a unique recommendation?
So as I was saying earlier, I worked for 10 years for the clinic Braverman Reproductive Immunology, and Dr. Braverman, who sadly passed away a couple of years ago, was really a pioneer. He has been using immune testing for years, and I'm talking back in 2010 or even before. So we accumulated a very valuable data set of patients that were screened prior to conception, during the pregnancy, and we have all the details of their immune therapy, all the detail of their test results prior to conception. And we were able to run some statistics using artificial intelligence to try to compare the profile of patients who end up having a baby versus those who failed, and see what were the key parameters, at what level those results were expected to be to have a successful pregnancy. So whenever you have a NIRMA report, we are looking, of course, at those tests individually, but then all the test results are put into our black box, and we are able to generate a score that will tell you how likely you are to be successful based on those 60 test results.
60. Did everybody get that? 60. All right. So, it's when you are a single physician looking at, 4, 10, 15, 20 tests, right? But you're not just looking at 60 tests. You're combining it and actually looking at how they interact with each other to come up with the best thing. The most important thing is what's best for the patient, and how can you individualize the plan? Because it's not a one size fits all, right? If it were one size fits all, we wouldn't be here. We'll just, find the magic formula and just apply it to everybody. So everybody's really different. And it's really a very frustrating problem for patients that causes a lot of angst and anxiety. And I'm glad someone like a company like Pregnu is available that can give us this information that is actually based on artificial intelligence, AI. It's not just a human being looking at it. And I understand that you have ongoing studies, so it's not like it's not a one-done deal. You're still analyzing all these patients that you have in your database.
Yeah, we are trying to fine-tune this algorithm. So we are sending follow-up questionnaire to patients who did have a NIRMA report to try to see if they try to conceive. If so, what treatment regimen they were placed on, and try to see what outcome they had. And we are placing those results back into our algorithm, trying just to find and to adjust the formula to predict as best as we can the success that you may have.
Excellent. Thank you so much. So at this point, I'll say if anyone has any questions, we're open for any questions you may have. But in summary, I don't want this to go on too long. I thank you for being here, and I know you could be eating dinner. Thank you, Dr. Mansouri-Attia, for really taking the time out of your super busy schedule. I'm grateful to everyone who's here. But my goal was to shed information, to shed new data, because this is just fascinating. It's interesting. It's cutting edge, and there's a lot of research that's still ongoing. And it's exciting to be able to see data that may have some clinical application for patients who otherwise they will tell, well, just give up, go adopt, and that's it, correct?
That's correct, yeah. Despite the progress of technology, we have seen PGTA helping a lot. You know what you are working with. Euploid, normal genetically, embryo, that's great. You have a functional test with the ERA looking at optimal window of implantation to have the best timing for the transfer. Great. Still, we have patients suffering from RPL, recurrent pregnancy loss, patients who failed multiple times with euploid embryos. I have seen today a report that I have done, 13 loss. That shouldn't happen. We have to seek help when it's more than 3 loss with euploid embryo. When the patient is fairly young, she had 3 loss. There is something else going on, and we have to find a solution. And I think PregImmune is here to help those patients.
Thank you so much. I really totally indebted to you, and I've learned so much from you. I always tell myself I try to learn something new every day, but this is really fascinating. So you know that I am completely staying in touch, and I can't wait to see all the newer things coming out and how we can, and maybe when we have this conversation next year, things may have radically changed.
Yeah,
But
hopefully, yeah.
Yes. Thank you once more. Thank you everybody for watching us. This webinar will be on YouTube. It's streaming on YouTube right now, and it will be there where you can catch a replay. And if you have specific questions that are concerning, please submit them, forward it to me. I can forward it to Dr. Mansouri-Attia as well. And that would help us give you more information in the future and guide more of our talks. As I look forward to our next talk then. Thank you so much.
Thank you.